I'll be sharing findings from a rapid review focused on suicide and self-harm prevention in older adults that was finalised at the start of this year. So we initiated this review in response to the rising suicide concerns among older adults in North Wales, a growing demographic often overlooked in previous strategies. So I'm going to briefly start by walking through the methodology behind this review. So this review was guided by three core questions. The first being, what is the prevalence of suicide and self-harm amongst older adults in Wales and the UK? The second question was around what are the main risk factors for suicide and self-harm in this age group. And the third was around what interventions are effective in preventing suicide and self-harm in older people. So we conducted a systematic literature search from the year of 2014 up to 2024 and focused on individuals aged 60 and over. And we used Embase, Medline and PsycInfo as our search bases, and with support from our BCU library service team in conducting the searches. Then titles and abstracts were screened, followed by the full text of all the reviews, and out of the 51 studies on risk factors and then 56 around interventions, a grand total of 27 papers were included in the final review. And these comprise from systematic reviews, meta-analysis and observational studies. And then the thematic analysis was then conducted in order to identify and learn from the risk factors and interventions that were included in order to understand the challenges and effective support for older adults. So suicide rates among older adults reveal important regional and demographic patterns. And in 2022, Wales recorded a higher suicide rate of 12.5 per 100,000 compared to 10.5 per 100,000 in England, highlighting their regional disparities. And older males, particularly those aged 90 and above, had the highest suicide rate at 32.1 per 100,000, showing the increased vulnerability in older age. Well, female rates are generally lower. The highest rate among women was in those aged between 50 to 54 age group, suggesting that midlife transitions may be a key risk in that period. So importantly, self-harm among older adults is underreported, especially in rural areas due to stigma and self-stigma and limited access to mental health services, reducing visibility and delaying support. Seasonal trends are a key factor in suicide rates, which peaks between April and June. Suicide rates in spring and early summer can be 2 to 3 times higher than what's recorded in December. And these fluctuations can be driven by changing daylight, biological rhythms, and levels of social isolation. And older males are at increased risk due to the social and health-related factors and vulnerability, highlighting the need for targeted interventions during high-risk periods. So from the literature, several international models stood out for their practical impact. So let's take a closer look at what was learned through some of those approaches. So in Australia, suicide prevention efforts in long-term care facilities have focused on gatekeeper training for staff. And this initiative equips caregivers and nursing home personnel with the skills to identify and respond to suicidal behaviours amongst their residents. And the training includes modules on depression screening, life review therapy and mental health awareness. And the life review therapy in particular encourages the residents to reflect on their life experience, fostering a sense of meaning and acceptance. And early evaluation from these programmes have shown reduced depression scores amongst the residents and improved staff confidence in managing mental health concerns. And by enhancing the capacity of long-term care staff to recognise and address psychological distress, these interventions contribute to a safer and more supportive environment for older adults. And the Australian model underscores the importance of workforce development in suicide prevention and the value of psychosocial interventions in care settings as well. And then the Netherlands has adopted a model of integrated mental health care within general practices to support older adults. And mental health services are embedded directly into the GP practices, allowing for coordinated care that addresses both physical and psychological needs. And this approach includes cognitive therapy, physical rehabilitation, and social support activities tailored for the elderly. The integration facilitates early intervention, reduces stigma associated again with mental health treatment, and ensures that the older patients receive holistic care. And then evaluations of this model demonstrated effectiveness in reducing depressive symptoms and improving overall well-being by combining medical and psychosocial support with a single care pathway. The Dutch system exemplifies how integrated care can enhance mental health outcomes for the older adults. And this model in particular is relevant for regions seeking to streamline services and improve access to mental health care for the ageing populations. And then comparably here in the United Kingdom, the National Institute for Health and Care Excellence has developed the guideline NG222, which advocates for collaborative care models specifically tailored to older adults with chronic physical health conditions. And these models integrate mental health professionals directly into primary care settings, enabling systematic screening and follow-up for depression and suicidal ideation. And the approach ensures that older patients receive timely mental health support alongside their physical health management. And by embedding mental health services within general practices, the model facilitates early detection of psychological distress and promotes continuity of care. Outcomes from this implementation have shown improved depression management and a measurable reduction in suicide risk amongst older adults. And this model exemplifies how structured, integrated care can address the complex needs of ageing populations and reduce mental health disparities. So, drawing together the evidence from across the studies that we read, some clear themes emerged, and these insights helped us then to shape and set practical system-wide recommendations for improving suicide and self-harm prevention in older adults. So here's a summary of what we learned. Firstly, the risk factors, older adults at risk of suicide and self-harm often face complex, intersecting challenges, including social isolation, chronic illness, bereavement, long-term unemployment, and stigma around mental health. These factors are frequently under-recognised in clinical and community settings. And then to address this, the insights that has been gathered demonstrated that there's a need to be a multi-pronged approach around it all. So to train frontline staff and GPs to detect and respond in a respectful manner to suicidal behaviours using collaborative and gatekeepers models. To embed holistic care by integrating mental health, physical health and social support services, particularly for those with long-term conditions or recent life transitions as well. To strengthen community engagement through peer-led initiatives, befriending schemes and culturally sensitive outreach, especially in rural areas and underserved areas as well. And to improve data sharing and coordination across health, social care and third sector organisations to ensure timely support and continuity of care. And to promote age-inclusive suicide prevention strategies, ensuring all adults are visible in national and local plans. And these recommendations are interdependent and should be implemented as part of a system-wide response tailored to local context and co-designed with older people themselves included in the designing as well. So in conclusion, suicide in older adults is a multifactorial issue shaped by physical, mental and social dimensions. Effective prevention requires holistic, evidence-based approaches tailored to the unique needs of our population. And collaboration across healthcare, social care and community services is essential to implement and sustain impactful interventions. And by embedding these strategies into our system and practices, we can create a safer, more supportive environment for older adults across Wales. So as we move forward from today's webinar, let's each of us consider what role can we all play in ensuring older adults are not left behind in our suicide prevention efforts, whether through policy, practice or community engagement. Every action counts. Diolch, thank you.
Diolch yn fawr, Siwan. Really excellent presentation there. Thank you so much.